Good morning, good afternoon, and good evening to everybody. I am Maria Sedano, and I'm a critical care nurse by background. A senior clinical manager for vascular access in Europe at Clinical and Medical Affairs in Teleflex. On behalf of Teleflex, I would like to thank you all for joining this event. Many ICU patients who receive a central venous catheter have something in common. They are critically ill patients and may require a CT scan. Teleflex has a compelling experience with regards to vascular access devices, with more than 30 million CVC Aerogard protection sold globally and recommended by several international and European guidelines, such as SIA, CDC, ENS, to mention a few, for the prevention of catheter-related bloodstream infection. However, this is not enough to help protect our patients. The amount of procedure in which contrast is injected through a CVC is unknown. However, surveys conducted on European clinicians in 2020 showed that almost 48% of non-pressure injectable CVC are used off-label to perform CT scan with high pressure. Catheters may weaken without any external sign of damage, shortening their lifespan due to occlusion, late non-function, and potentially late rupture, and this can put our patient under additional and unnecessary risk. At Teleflex, we profoundly believe that proven impregnated catheter technology and pressure injectability should go hand in hand, and this is why we are pleased to have you all here, listening what experts in this field have to tell us. Let me inform you that this event will be recorded. Between sessions, a poll will appear on the screen for 1 minute, in which we hope you accept to answer. Moreover, in any moment during the event, you can send your questions and you can ask to be contacted by our team. It's now the moment to start the event, and we are pleased to give the floor to our moderator. Professor Anil is a consultant in anesthesia and critical care medicine at the Rotterdam NHS Foundation Trust in the United Kingdom. He also works as a consultant in major trauma at Sheffield Teaching Hospital, NHS Trust. Professor Hormis has published several articles, abstracts, and book chapters in the field of anesthesia and critical care medicine. He has been invited as a guest speaker at many national and international conferences. He has been heavily involved in teaching and training for many years and has run numerous cadaveric procedural skill courses throughout Europe. Professor Hornis, welcome.
Maria, thank you for that introduction. It's a real pleasure to be asked to moderate the webinar today, and I'm so pleased to see so many people registered here today at the webinar. The topics to be presented today are of great importance to the day-to-day work that we do in the critical care unit and the emergency department. We are really privileged to have truly expert panel of speakers today from across the globe, and I really look forward to hearing their talks and learning from them. As Maria said, we'll be running some polls before each speaker, and I encourage you to vote in the polls. We're also going to have a Q&A session at the end, which will have all the panel free to answer questions. So please submit any questions you have into the chat box, and please write the questions in English and specify which speaker you'd like me to address them to. So we'll have the first poll now, if we can. So the first poll will be, the question is, in your organisation or hospital, how important is it to lower CVC infection rates? Okay, and the answers you can give will be, it's critically important, it's highly important, it's somewhat important, or I don't know, or I'm not sure. Okay, so I'll repeat the question. In your hospital organisation, how important is it to lower CVC infection rates? So the results are coming in. There's many of you who are voting. So highly important, critically important, somewhat important, or you don't know or you're not sure. Okay, so we've got a relatively good spread. So about 38% of you say that is highly important, 38 going up now. So 40% highly important, 35% critically important, and 16% say somewhat important. Okay. So the talks that we're going to have for you this afternoon cover a range of aspects of CVC lines. So we're going to introduce you to Professor Rupp very shortly, who's going to be talking about catheter-coated technology for the prevention of catheter-related bloodstream infections in ICU patients. Dr. Greca is going to talk about power injection and some technical pearls on the role of power injectable CVC lines. And finally, Dr. Lamperti is going to talk to you about how much pressure are you willing to support in your ICU patients, and he's made this choice very easy. So it's my absolute pleasure to introduce our first speaker today, Professor Mark Rupp. He's a professor and chief of division of infectious diseases in the Department of Internal Medicine at University of Nebraska Medical Center. He is also the medical director of the Medical Center Department of Infection Control and Epidemiology. Dr. Rupp has published over 450 articles, chapters and abstracts. He frequently presents papers at national and international meetings, serving as a guest lecturer. He is an active teacher and researcher, and his research interests are all linked to healthcare-associated infections and antimicrobial stewardship. So Dr. Rupp is going to talk to us about catheter-coated technology for the prevention of catheter-related bloodstream infections in the ICU. So please let me hand over to Professor Rupp.
All right, good day to everyone. I'm absolutely delighted to join the group and quite honored to do so. And if my next slide can come up, please. Thanks. Obviously, I do have disclosure for conflict of interest, and that is that Teleflex is providing me an honorarium to provide this presentation today. In the next 20 minutes or so, I'm going to try to talk a little bit about the epidemiology and the significance of catheter-related infections in our critically ill patients. It looks like I have a pretty easy job with regard to that point, in that nearly everybody in the audience responded that infections are either very important or critically important to this group of patients. And then we're also going to describe an evidence-based approach to trying to prevent those infections with a concentration of information on coated catheter technology. So let's go ahead and get right into the clinical significance and epidemiology of these infections. Here in the United States, we've been very effective in decreasing what we call CLABSI, central line associated bloodstream infection. And in the latter part of the last decade, about a 50% decline in infections were observed in the United States. Having said that, however, we continue to see tens of thousands of patients in our ICUs and in other hospitalized patient populations that continue to have catheter-related bloodstream infections. And you can see on this slide that the rate of infection ranges somewhere between almost non-existent in some units that have been very effective in preventing infection, all the way up to about 3 per 1,000 catheter days. A little bit more recent data is also shown on this slide, where again, documenting that tens of thousands of patients continue to experience these infections and that they continue to be very impactful with regard to morbidity, mortality, and excess costs. Data from Europe, closer to home where most people in the audience are today, you can see this data from the European CDC looking at catheter-related bloodstream infections. And I think this is an important distinction that we need to establish right away, that there is a difference between central line associated bloodstream infections and catheter-related bloodstream infections. Catheter line associated BSI, or CLABSI as we call them, is a surveillance definition, and CRBSI generally takes more clinical information to really establish the catheter as the source of infection. However, what you can see on this slide is similar to data from the United States. When you look at CLA-BSI and the impact on mortality, it is statistically significant. As you can see also, however, when you try to define the source of the bacteremia more closely and use a CRBSI definition, that distinction becomes less clear. And in this set of data, there was actually not an attributable mortality seen from CRBSI. Further data from the European CDC looking at CRBSI across a number of ICUs shows that in data very similar to what we see in the United States, you can see that the mean rate of CRBSI ranges from almost 0 in some units, albeit quite a small number of ICUs reporting, for instance, in Belgium, up to outliers, as you can see in this data from Hungary, with again, a very small number of ICUs. But for the most part, what we're seeing is an infection rate of somewhere around 1, 2, or 3 per 1,000 patient days in units throughout Europe. And then on the right-hand side of the slide, you can see using a definition of CLABSI, again, similar data to what we see in the United States, with the infection rate having declined somewhat down to a level of perhaps 1 to 1.5 infections per 1,000 catheter days, and then rising a little bit over the last part of the last decade, potentially. So let's go ahead and shift gears and talk a little bit about how we prevent these infections. And what I would relate that for all persons who are receiving a central venous catheter, and for those people who are inserting those central venous catheters, we clearly need to look at the indications for catheterization and try to choose the most appropriate catheter. Obviously, we want to have the least invasive, least dangerous type of vascular access device as we can in any particular patient. The people inserting those catheters need to be very carefully trained and validated, credentialed that they are capable of inserting central venous catheters appropriately. Oftentimes, this training is done in simulation labs now, using very sophisticated educational and simulation techniques. We need to make sure that the staffing and the personnel is appropriate for the care of that degree of illness in a patient. So in our ICUs, oftentimes we may have 1-to-1 ratio of nurse to patient to take care of somebody who's truly critically ill. When the catheters are inserted, an insertion bundle should be used in which maximal sterile barrier precautions are used. So the person inserting the catheter should have on sterile gloves, a sterile long sleeve gown, a cap, a mask, and a drape that covers the patient from head to toe. A chlorhexidine alcohol combination disinfectant should be used to disinfect the skin prior to the insertion of the catheter. And a checklist should be used to drive the whole process to remind people to do the right thing every time. Now, after the catheter is inserted, it's important to take care of the catheter appropriately. So people accessing the catheter should use careful hand hygiene. The dressing should be maintained. It should be changed whenever it is loose, soiled, damp, or needing to be changed. Every time somebody accesses the catheter, the hub of the catheter or the connector port should be carefully scrubbed to disinfect it. Some places are using passive port protectors to try to take the human element out of that. And some institutions are using a chlorhexidine impregnated dressing to try to ensure that there is a barrier at the site of the catheter insertion. Some institutions, particularly here in the United States, are bathing their patients with chlorhexidine. I think this is a difference between practice in the United States and in many places in Europe. Here it is a fairly common procedure in the US. I know in Europe there's an increasing concern around chlorhexidine decreased susceptibility if we widespread use chlorhexidine bathing. And then of course, central venous catheters should be removed just as soon as they can when somebody doesn't require that degree of vascular access. So after the catheter has been placed, let's take a look at some of the innovations, particularly around coated catheter technology. Now, before I go into that, this is one of my favorite quotes from one of our mentors here in the United States, Bob Weinstein, who said, "If you can choose between education and influencing human behavior or introduction of a gizmo, choose the gizmo every time." Now, I don't know how well gizmo translates into the various languages that you're listening in, but it's essentially a device. And what Bob was trying to relate here is that if you can take the human behavior aspect out of standardized care, that sometimes is your best way of providing quality care to a patient. We all know that trying to get people educated and changing their behavior sometimes can be very, very difficult and stubborn. And if you can get around that human behavior issue by introducing a device, again, sometimes that's your best way going forward. However, another quote is that it's impossible to make anything foolproof, because fools are so ingenious. And what I mean by this is that no matter what type of technological innovation we introduce, if people are not careful and if they're not practicing aseptic practices when they insert and care for catheters, they can overwhelm that protective technology. And so it's important that we do both things, that we introduce innovative technology and that we also continue to use standardized aseptic practices when inserting and caring for central venous catheters. So some of the technological approaches that are available to us now are using coated central venous catheters, impregnated dressings, primarily with chlorhexidine, antiseptic caps, sutureless securement, and catheter lock solutions. Now, some of these modalities have more data than others, but clearly one that I want to concentrate on today is central venous catheter coating technology. And there's a variety of coatings that are commercially available. Those are shown in this slide. Here in the United States anyway, the two catheters that are coated with chlorhexidine and silver sulfadiazine, or the minocycline rifampin coated catheters, have the major market share. But there are other choices available as well, such as the silver platinum carbon catheter, miconazole rifampin, benzalkonium, and benzalkonium, along with an anticoagulant heparin. Now, these disinfectants and antibiotics work in just a little bit different ways. Those modalities of action are shown in this slide, where chlorhexidine, an antiseptic, has a very broad mechanism of action by disrupting cell membranes. Likewise, silver, a disinfectant, deactivates enzymes and membrane transport by binding to the thiol groups and is a pretty generalized antiseptic mechanism of action. Now, sulfadiazine, rifampin, and minocycline are antibiotics, and they have more specific modalities of interaction with microbes. So sulfadiazine inhibits folate synthesis, rifampin inhibits the RNA polymerase, and minocycline is a tetracycline antibiotic, obviously, that inhibits bacterial protein synthesis. So there are different mechanisms of action with these compounds that are used to coat catheters, and because of that, they have a little bit different spectrum of activity. Now, that different spectrum of activity can be shown on this slide, where catheter segments have been put into an agar plate that is coated with different types of microorganisms. In this case, it's Staphylococcus epidermidis. And what you can see is around the control catheter here in the upper right-hand corner of this agar plate, the organisms grow right up to the edge of the catheter. There's no zone of inhibition. Here with the chlorhexidine sulfur sulfadiazine coated catheter in the upper left-hand corner of the agar plate, you can see a good range of inhibition. Likewise, with the minocycline rifampin coated catheter, you can see a large zone of inhibition. And then with the silver cardamom platinum catheter, you can see less of a zone of inhibition. On the right-hand portion of the slide, you can see that the levels of inhibition gradually deteriorate. You can see it's well maintained with the minocycline rifampin coated catheter out to 7 days. The chlorhexidine silver sulfadiazine catheter, a little bit less zone of inhibition, but likewise is maintained out to about 7 days. And then the silver carbon platinum catheter is extinguished within that first week. Now, I'm seeing some chat messages that some folks are not able to see my slides. I'm sorry if that's the case. I'm going to keep going forward. I don't know what I can do about that. I'm seeing the slides quite readily. The next slide shows the spectrum of activity against Pseudomonas aeruginosa. You can see that in this slide, again, right up to the edge of the catheter segment on the control catheter, you have growth of organisms. There's a reasonable zone of inhibition around the chlorhexidine silver sulfadiazine slide, less zone of inhibition around the silver carbon platinum, and very little around the minocycline rifampin. And then that, again, is shown on the right-hand portion of the slide with the chlorhexidine silver sulfadiazine slide, showing good activity out to 7 days with very much less activity from the other two catheter coatings. This is understandable because those catheter coatings have very little activity against some of these gram-negative bacilli, such as Pseudomonas. And then the next slide shows activity against Candida. Again, in some ICU populations that are high at risk of fungal infections, this can be an important pathogen. And this slide shows a smaller but reasonable level of activity with the silver sulfadiazine chlorhexidine catheter and very little activity with the other coatings. And again, that's shown on the right-hand portion of the slide with the level of inhibition over a week's period of time, with silver sulfadiazine having a fairly good level of inhibition, very, very little with the silver cardamom platinum that's extinguished at 3 days, and essentially zero level of inhibition with the minocycline rifampin coated catheter. One question that we sometimes are asked is, what is the duration of activity? That's shown in this slide. On the left-hand side, you can see first-generation coated catheters with silver sulfadiazine and chlorhexidine, with a level of inhibition that goes out for the second-generation catheter out as long as 5 to 6 weeks. On the right-hand portion of the slide is some studies that we did in our lab, where we took explanted catheters from nearly 60 patients, put them into our auger, almost like a disc diffusion test, as I've just explained, and you can see that there's a good level of activity, certainly out to about 3 weeks, and then we had a few outlier patients all the way out to 5 to 6 weeks that likewise had good levels of activity. Now, can catheter colonization be used as a surrogate marker for bloodstream infection? I think the answer to that is yes. As we have decreased the level of CLABSI lower and lower, it gets harder and harder to actually study this subject. And so sometimes I think using a surrogate marker for infection makes sense. This is from a meta-analysis that shows a very close level of correlation between catheter colonization and the incidence of catheter-related bloodstream infection. So I think we can use this as a surrogate marker for studying additional coatings and additional innovative technology. Now, do catheter coatings prevent bloodstream infection? Again, I think the answer is a resounding yes. Here is data from a large meta-analysis looking at the top part of this slide for the first generation chlorhexidine silver sulfadiazine coated catheters. You can see that there's about a dozen studies here. The relative risk is 0.68, meaning that about 30% of the infections were prevented by the use of the first generation catheter. And you can see the mean and then the 95 confidence intervals for all of these different measures. For the second generation coated catheters, they appeared to be somewhat more effective with a odds ratio of 0.47, meaning that about a little over 50% of the infections were prevented compared to non-coated catheters. And then from the same meta-analysis, looking at the minocycline rifampin coated catheters, you can see that the odds ratio was 0.29, or about 70% of those infections being prevented. Now, a lot of people look at this data and they want to jump to the conclusion that the minocycline rifampin coated catheters are more effective. But what you may have noticed in the previous slide and in this slide is the percentage of infection in the control group of patients. And what I would point out to you is that the rate of infection in the minocycline rifampin coated studies was actually significantly higher than it was in the chlorhexidine silver sulfadiazine coated catheters. None of these studies were direct comparisons, and therefore I think that these studies are not really adequate to compare one type of catheter to another. What I would relate is that both of these coatings seem to be very, very effective in preventing central venous catheter associated infections. Now, this is another meta-analysis showing the comparison between the catheters and the controls. Again, pretty much the same conclusions as the previous meta-analysis. And I would just reinforce to the audience that this is a very well-studied technology. What you can see here is that the chlorhexidine silver sulfadiazine coated catheters versus the standard uncoated catheters, the odds ratio was 0.64. So very much like what was shown in the previous slide, preventing around 35% of those infections. The antibiotic coated catheter, the rifampin minocycline coated catheter, had about half of the infections prevented in this meta-analysis. And then the platinum silver carbon catheters had a slightly less favorable odds ratio of 0.7, again, showing that about 30% of those catheters were effective in preventing infection. The same thing is true for PICCs as it is for other central venous catheters. Here's a nice meta-analysis showing in almost 1,500 patients, the CLABSI rate decreased and the odds ratio was 0.21 when using coated catheters. They found no difference between the coating type between chlorhexidine and rifampin minocycline. There's a variety of novel antimicrobial coatings that are also being looked at and is shown in this slide. I'm not going to go into any details on these non-available coatings, but just reassure the audience that the work continues on looking for the best coatings on central venous catheters. And then I'm going to end with just a few comments about things that we don't oftentimes think about, particularly in some of our critical care patients. But part of the equation in preventing vascular catheter-associated infections is paying attention to all the vascular catheters. And this is true for peripheral IVs as well. I think that in many cases we disregard peripheral IVs and we don't give them the respect that we should. You can see that almost 2 billion peripheral IVs are used throughout the world every year. And then this is a little bit of data to show that those peripheral IVs can actually be very impactful. I would point you to the bottom part of the slide where Len Mermel looked at the bloodstream infection being in about 0.2% of over 85,000 peripheral IVs that were looked at, and that peripheral IVs were responsible for 23% of catheter-related bloodstream infection. So I think that, again, peripheral IVs are something that is relatively neglected and something that we should actually focus on more greatly. Likewise, midlines, sometimes used here in the United States because it doesn't count as a central line because obviously they are a different form of a peripheral IV. Frankly, I think this is somewhat disingenuous and something that shouldn't be done, but human beings and the folks who run hospitals will respond to pressure, and if they're being penalized for their CLABSI rate, they'll find different kinds of catheters to be used. And I think this data demonstrates that the midline catheters can be associated with central line or with bacteremia, and that the difference in the bacteremia was not statistically significant between midlines versus central venous catheters in this particular study. So again, I think midlines can result in bacteremia. We do need to be careful with them, and they should not be neglected. And then lastly, what about arterial catheters? Obviously, in critically ill patients, these are very frequently used. The data would suggest that arterial catheters can be associated with bloodstream infections. Some studies have shown that the risk of infection is just as high as central venous catheters. And this slide shows that in many instances, people are not inserting arterial catheters with the same level of precautions that they do for central venous catheters. And they're, again, I think, somewhat a neglected source of bacteremia, and we should be paying attention to them. So with this, I'll go ahead and end my presentation and turn it back over to the moderator. Again, I want to just express my gratitude for being with the audience. It's a terrific honor and a pleasure for me, and I'll look forward to the discussion going forward. Thank you.
Mark, thank you very, very much for that talk. I think that was a really useful overview of catheter-related infections, some very useful tips on CVC care. And I think for me, my take-home message is, still the importance of aseptic technique in placing the lines in the first place, I think is absolutely crucial there. So thank you very much. Okay, we're going to go through to another poll in a second. Just one thing, a couple of people talking about not being able to see the slides. If you just refresh the page and press play, that should hopefully sort out the issue if it's a Wi-Fi problem. Okay, so guys, I'd really like you all to take part in the next poll. The question is, on average, how many central venous catheters do you personally insert on a weekly basis? Less than 1 a week, 1 to 2 per week, 3 to 4 per week, 5 to 6 per week, more than 1 a day in busy units, or there's some people who don't actually place CVCs themselves. So please, everyone, please have a vote so we can get a really good representation of what people's practice is. So on average, how many CVCs do you personally insert on a weekly basis? Okay, we've got a few people voting. Can I encourage some more people to have a vote? So the large group of you who don't place CVCs, okay, 1 to 2 per week, 3 to 4 per week. There's not anyone yet who says more than 1 a day, so that's the record. Okay. Any more? Encourage you just to have a vote. Okay, so there was a large group there who didn't play CVC. So you know, for you guys, welcome to the talks, and I'm really hoping that you'll be able to learn something about this and central lines. Okay, so my next pleasure is to introduce our next speaker, is Dr. Antonio Greca. He's an emergency and trauma surgeon from Rome, where he directs the visceral trauma unit and coordinates interdepartmental central venous access center. In the last 10 years, he's become an essential part of the faculty in multiple training programs in collaboration with the European Society of Trauma and Emergency Surgery. He's co-developed multiple training programs for vascular access within the activity of the Italian Working Group for Vascular Access, and he is a peer reviewer for the Journal of Vascular Access. The title of his really interesting lecture is about power injection and surroundings, some technical pearls, and the role of power injectable CVC access devices. So Antonio, I'll pass over to you. Thank you very much.
It's a big pleasure to be here with you, even only on the web. I hope to meet you again personally in the next feature. In this next 20 minutes, I will try to explain the role of power injection and the meaning of power injectability, so power injectable devices, which indeed are two different concepts. Okay, two different concepts. Power injection is a radiology procedure consisting in an IV administration of a contrast media under high pressure, up to 300 pounds per square inch, at the high flow rates, more than 2.5 milliliters per second, with the aid of an electronic control device. So this is a diagnostic procedure. While power injectability is a specific feature of a vascular access device, which is built with strong materials that prevent structural damage to the device itself during high pressure infusion. So the first question to answer is, do we need power injection? And when do we need power injection? We have at least two big pools of reasons, diagnostic and other reasons. Other reasons are the issue, the matter of the next lecture, so I will not deal with it. But we have a number of diagnostic reasons. Generally speaking, contrast media infusion parameters influence CT image quality, and these parameters are basically flow, total volume, and injection site distance. Flow and total volume depends on the flow rate. That means that if we need good images, we have to push the contrast media under high pressure to obtain high flows and then have a concentrated column, avoiding so the dilution of the contrast media while this is reaching the parenchymal organs to study. And the contrast, the whole volume to be administered depends on the capability of the machine to get images in a short time, as well as the flow rate of the contrast media itself. This is what happens when we inject contrast media at different flow rates. As you can see, at the high flow rates in the black line, the concentration of the contrast media reaches a peak and then decreases rapidly. And this is crucial to have good contrast enhanced images of the parenchymas and to have a good washout in order not to confuse the different phases of the study, arterial, venous, and portal and late. And this, you can see here, if we inject a contrast media at a flow of 3 milliliters per second, this is the image you obtain, and this is the image you obtain if you increase the flow rate. So the contrast enhancement of the parenchymas increase. So the diagnostic effect of power injection is a better visualization of the vascular tree in the target organ before the parenchymal distribution of the contrast media itself. This allows a differential and predictable parenchymal enhancement for better specific imaging of different organs, especially due to a good washout and separation of the different phases of the study. This also allows lower contrast media volume administration, so preventing toxicity while preserving image quality. And last but not least, this technique offers quantifiable and reproducible comparable results as required by the RECIST criteria in oncological studies. So do we need power injection? The answer, of course, is yes. The second question to answer is, do we need power injection via CVC? Injection site distance matters. Matters because if you inject the contrast media far from the heart, while reaching the heart, the contrast will get diluted, while we need it to be concentrated and to have a concentrated column of contrast media reaching the organs quite compactly. So usually infusion of contrast media through a CVC would allow the use of lower flow rates and lower volume as compared to an infusion via peripheral vein. As you can see in this image, on the left side, contrast media infused in via a peripheral cannula gets diluted already before reaching the right atrium, while if it's infused in a central venous catheter, the tip is quite near the right atrium and the contrast media remains concentrated, ready to be distributed to the parenchymal organs under study. So power injection via CVC grants an optimal parenchymal imaging. The bolus proceeds more uniformly across the venous system and obtaining a quick and compact injection. This is what happens after the contrast media has reached the heart. As you can see, if you inject via peripheral cannula, the aortic arch is not so well contrast enhanced, while if the contrast media is injected via CVC, this gives a quite better concentration even after the contrast media has left the right chambers of the heart. This is quite crucial for oncological study because, as you know, the RECIST criteria need strict evaluation of morphological and quantifiable parameters of the lesion under study. And this is crucial to choose different cytotoxic protocols. So the concept of measurable disease in oncology. So last but not least, we know that power injection via CVC grants a quite superior comfort for the patients. These have been studied in several papers showing that having a CVC is quite comfortable for the patient. So do we need power injection via CVC? The answer is again yes. The third question to answer is, do we need power injectability? That means, do we need power injectable devices? Well, what we know is that extravasation of contrast media is a problem around the world. Global extravasation rate is around 18%, and it is clinical significant up to 1% in 1% of the cases. And this increases while increasing flow rates. That's the reason why in 2004, the FDA raised an alert concerning the misuse of venous access devices for enhanced power enhanced contrast media infusion. What happens is that basically the catheter gets broken, sometimes in a subtle way, like in the case of ballooning. That means that the catheter gets ballooned without rupturing immediately, but it can get ruptured later on. So the basic effect of this is loss of IV device, but even catheter embolism if damage occurs in the endovascular tract of the catheter, or extravasation and tissue damage if the damage occurs in the subcutaneous tract of the catheter. And what we know is that standard materials do not support high pressures, as silicone and standard polyurethane. And also, we know that even hand-driven pressure can reach high levels of pressure on the device, while complex catheters need to be kept at very low flow rates in order to avoid damage to the device itself. And we know that catheters have multiple weakness points: the tip, bifurcations, the hub, and any connection, as well as for total implantable vascular access devices, which is not the goal of this lecture, but this is a problem as well. And this is what happens if we do not care for this problem. So power injectable devices were introduced into market since 2004. And the reason for this is that they allow high flow rates, up to 10 milliliters per second, at 300 pounds per square inch, and they are clearly labeled and identifiable, so operators can use them safely, and they're easy to use. Basically, the power technology involves an ultra-resistant polyurethane, modified polyurethane, and special glued connections in order to increase the global strength of the device. And this offers further benefits. Having a CVC bearing allows repeated contrast enhanced imaging. This is particularly important for critical patients, for oncological patients, and in any patients whose treatment protocols highly depends on CT scans, such as acute necrotizing pancreatitis or abdominal infections, and necrotizing soft tissue infections and whatever. Moreover, power injectability, increasing breaking strength of the device, allows higher infusion flow rates, even with non-contrast infusions, such as blood in critical patients or trauma patients. These devices have lower rates of kinking, fracture, and dislocation, lower obstruction rates, and it's easier to manage their obstruction, and can be used for hemodynamic and metabolic therapeutic procedures such as filtration, pheresis, ECMO, PICO, and advanced hemodynamic monitoring. This becomes feasible even with long catheters such as peripherally inserted central catheters or long femorally inserted central catheters. So this becomes an effective option in ICU patients as well as in other settings. Indeed, indications for power injectability have increased, and now we use them in hospital non-ICU patients, in oncology patients, in home care, such as palliative care and nutrition. They offer great benefits even in this kind of patients. So do we need power injectability again? The answer is yes. The answer is yes, and that's the reason why the market is expanding. Now, companies are producing conventional CVCs as well as tunneled catheters, or PICC lines, or femoral inserted central lines, or peripheral cannulas and midlines under power injectable technology. And so now almost 90% of the whole market is full of power injectable device. This is an example of the crucial use of power injectable device in a common ICU, such as in our hospital, in 18 beds ICU unit, where during a walk around on Sunday, it was a couple of years ago, 80% of patients had multiple CT scans during their stay in the ICU, such in this patient, 12 contrast enhanced imagings in 1 month. That means one every 3 days. And you can easily understand the role, the importance and the role of a power injectable device in a context like this. And the ICU is a model of environment where a multi-tool vascular access device is very important. We use power and antiseptic devices. You heard about this in the previous lecture. And we published an extended pattern of indication for these devices, including patients with diagnosed bacteremia or suspected bacteremia who strictly need a CVC, but they cannot afford and eventually a catheter-related bloodstream infection. So we are talking about multi-tool devices. We have power injectable and antiseptic device catheters in one single device. We hope to develop antithrombotic and anti-sleeve catheters as well, and to merge them in a single device, like this company is trying to do, and hopefully in an all-in-one kit, including all the devices you need for the procedure and to prevent all the complications, septic and non-septic. Well, central catheters still face a delay in developing power technology, and this is strictly a matter of marketing and culture. Power injectable devices were born in Europe with peripherally inserted central catheters, and we need to expand this technology to central inserted ones. So to conclude, power injectable devices allow a safe and effective administration of contrast media under those high pressure regimens needed to obtain good quality imaging studies. And moreover, their breaking strength and high flow rates meet further non-diagnostic clinical needs as well. That means that device obstruction and prevention and management are easier to manage, and they allow even all those procedures, non-contrast based, that need high pressure and high flows of infusion. These power devices are a model to widespread the culture of safety and quality to all CVC's insertions, and we hope to have multi-tool devices, including not only power and antiseptic features, but also anti-sleeve features. And we're facing further research with more active materials and the concept of vessel health. So these kits should include high-quality guide wires, needles, and introducers with safety technology added. So the basic concept is that we believe in zero complications. This is an issue that have been exploited in infection control, and that we are extending to all kinds of complications. Thank you.
Antonio, thank you very, very much for that. I think you've highlighted two very important things there: the importance of power injection with some really fascinating CT images just to prove the point there, and also all the risks associated with not having a power injectable CVC, which you can tell is important and hopefully going to be used in other vascular access devices as well. So thank you very much for that talk, Antonio. And again, for the audience, if you have any questions for Antonio, please put them into the chat, and then we'll have some time at the end to ask him and all the other speakers some questions as well. So we're going to have our next poll now, which is coming up. Okay, so the next question I'd like to ask you all is, if you have a patient who has a non-pressure rated central venous catheter in and subsequently needs a CT scan with a high pressure contrast media injection, how will you handle the situation? Are we going to replace the current CVC with a pressure injectable CVC? Are we going to use the current CVC despite the potential risks? Or is that something that you're never really confronted with? So please, everyone, have a vote. There's only 3 options. So if you have a patient with a non-pressure rated CVC who needs a CT scan with high pressure contrast media, how will you handle it? This is a very, very common situation in all of the ICUs that we work on, I'm sure. Patients, as Antonio has shown, you need to go back for multiple scans And he mentioned conditions such as pancreatitis, and they know, and we all know that they need multiple scans. So how will you deal with it? Will you replace the current CVC with a pressure injectable CVC? Will you use the current one despite the risks, or is that something that you're not confronted with? Okay, so the votes are still coming in. Those of you who've not voted, please let us know your thoughts. And also just to remind you all that we'll be taking all the questions that you want to ask the speakers, and we'll have a Q&A session at the end. Okay, so the votes have come in now. So as you can see, about 50% of you have said that you'll replace the current CVC with a pressure injectable labeled CVC. So that's encouraging at this stage. Okay. Right then, so the next talk, I would love to introduce our next speaker. Dr. Massimo Lamperti is the clinical professor of anesthesiology at the Cleveland Clinic College of Medicine, and the chief of general anesthesiology in Cleveland Clinic in Abu Dhabi. He's a peer reviewer for many international index journals in the field of anesthesiology, critical care, pediatrics, and neurosurgery. He's an associate editor of the British Journal of Anesthesia and of the Journal of Vascular Access. We're very privileged. Dr. Lamperti is going to talk to us about his topic, which is going to be, how much pressure are you willing to support for your ICU patients? I made my choice easy. So Massimo, I'll hand over to you. Thank you very much.
Thank you for the introduction. And it's a pleasure to present to you my talk about the management of the catheters in ICU, especially in very sick patients. I have some disclosure to declare regarding my presentation tonight. And there are three main concepts that I wanted to discuss with you. One is, first of all, the need of a catheter in ICU, the possibility that we can have to choose the catheter for the right patient, and how we should prevent mainly the main complication related to a central line catheterization or even a catheterization on the patient that is related to the infection. I will present to you first the typical ICU patient, where most of the times we have the need to replace the volume because the patient is dehydrated or there was a shock. We need to know the hemodynamic status, and together with that, we need to even to know the respiratory status, sometimes with samplings of the CPO2 that are giving us a measurement of the metabolic, even the arrangement that the patient is having. In the meantime, most of these patients, especially in the recent period with the COVID, are going to have both a coagulative alteration and even an excessive immunoreaction. So in this case, it's important to understand which kind of catheter we should use in order to avoid and to resuscitate the patient. The ICU dilemma is mainly because is sometimes represented by patients who are volume depleted with acute kidney function failure, or a patient with a volume overload, but they are septic and so they have a reduced SVR, or the patient with severe sepsis who are having coagulopathy and hypoxia. Or in the most urgent scenario, we have patients with multiple trauma needing for fluid immediate resuscitation. This is a typical example, what I call the impossible Mr. Brown, a 60-year-old patient with past medical history of hypertension, diabetes, and renal failure, with a previous IVC obstruction and a vein fistula in the right arm. He's admitted to the ED for severe shock and bleeding. For esophageal varitis, the HB is 4, is severely hypotensive and hypoxic, and the pH is 7. So in this case, which kind of catheter we should use? Because we need to replace the volume, we need to transfuse, but in the meantime, we need to have even some exams to understand which kind of possible complication could happen in this patient. Possibly we even to do a CT scan to understand if what is the source of the bleeding. So the main dilemmas are even represented by thrombosis, that is a mixture of stasis, vessel wall injury, and hypercoagulability. As we know, the Poisson law is telling us that the lower we have a diameter in the vessel, the higher the resistance of the flow. And in this case, so the smaller the diameter, the lower the possibility to have an increased flow rate in our patients. So the first study that I studied the capability of the catheter to decrease the flow inside the vessel was done by Professor Nifong now almost 10 years ago. And in this study, very well nice done, even if it was in vitro, there was an assumption that the higher was the inner part of the vessel occupied by, in this case, PICC lines, the higher the possibility that there was a decreased venous rate, even up to 93% of the flow rate. And that was the first time that was presented the concept of catheter to vein ratio. In this concept, when we occupy part of the vessel with a catheter, so we increase the risk for the vessel to be obstructed. And further studies, mainly analyzing the possibility of PICC lines to create thrombosis, determine that if up to 45% of the catheter is occupied in the inner part of the vessel, we should avoid the risk of DVT. Several other studies are recommending a kind of rule of thumb where we can understand if we keep busy with like 50% of the internal diameter of the vessel with the catheter, we can increase the risk. And there are nice tables that are mainly helping with visual aids to understand how much of the vessel we can occupy. And if we go higher than 45%, we have an increased risk of DVT or even thrombosis of the vessel. In this way, the catheter to vein ratio is quite important to allow the catheter to stay as long as possible and to avoid as much as possible the risk for thrombosis. So this is one of the dilemmas, but the problem that we have in ICU are not only related to the thrombosis, but to the type of infusion, the duration, and the flow of the infusion. That's why we have multiple catheters, and according to the type of infusion, osmolarity, pH, possible endothelial damage, or maximum flow, we have different kind of catheters. We have the so-called peripheral IVs that can have a low osmolarity and a very limited pH, and then we have the central inserted central catheter, the PICC line, the FIC line, and the MAC introducer that can mainly allow a higher osmolarity and extreme pH. And we have even RIC catheters that are similar to peripheral IV, but are allowing very high flows, and in this case are very useful when we have to resuscitate with high volumes, especially patients with hemorrhagic shock. So these catheters are available in the market, and according to the kind of flow that we need, we can see that we can allow different and even maximal flows. For example, the RIC catheter is allowing 36 milliliters per minute of flow, per hour of flow, while even power PICC or central venous power catheters can have similar flow rates. And so in this case, if we need to both have a CT scan or even to resuscitate the patient, both with PICC line and central traditional catheter, we can obtain the same flow. The difference is that when we have a catheter that is power or not power, because in this case, the capability of the power catheter is allowing us to reduce the external diameter of the catheter, so maintaining a good catheter to vein ratio, but at the same time to allow the power injectability of the catheter and to allow the patient possibly even to have multiple exams through the CT scan. So there are different possibilities to insert these catheters in different venous accesses, like the arm, the trunk, the thigh. And again, we have to use the slow diameter, the smaller diameter, in order to reach a very good catheter to vein ratio. So several studies show that, for example, according to the different power, usually in the main CT scan infuser, we reach 300 to 400 psi, while the most rapid infuser, like the Vermont level 1, typically use lower psi from 5.8 to 300 millimeters of mercury. So there is even another question. Are we really not doing too many CT scans to our patients? This is a question that has been raised since 10 years ago, and probably even during the recent scenarios with the pandemic, we found that we are not really overusing the CT scans. The study published 7 years ago showed that the possibility to determine with the CT scan a new diagnosis is very helpful, and sometimes is really a game changer inside our ICU management. And almost in 50% of these patients studied in intensive care medicine were having a different diagnosis and could have prevented a further deterioration of the symptoms. While it was very strange to understand that 20% of these patients had an adverse event that occurred because the patient was transferred from the ICU in order to obtain the CT scan itself. So it is a very challenging problem when we have to use the CT scan in a wise way. And a recent study published, again, in intensive care medicine, showed that there are some alternatives to the CT scan, for example, the lung ultrasound that can predict, for example, a possible deterioration of the patient with the COVID SARS. So, but not all the times the ultrasound can be done or can substitute the CT scan. So that's why we need to have a catheter that can allow us multiple diagnoses on the patient. Another concept that we have to understand is the possibility of reducing the infection related to the catheter. So I will shortly remind you what is the definition of CLABSI, and it's not only something that has to be laboratory confirmed, but there are even several positive cultures that has to be done. And I give you some example of CLABSI. The first example is a patient who was placed in June 1st, became febrile after 2 days. The peak was in place, and then there was a positive culture for Staphylococcus aureus. The second example was a patient with a peak in place. The patient had the catheter removed after 3 days, became febrile after 1 day, and again had a culture positive for coagulus negative staphylococci. The definition, again, of CLABSI occurs when there are 3 criteria. First, the clinical sign of infection, like fever, hypotension, or altered mental status, no alternate source of bloodstream infection, and a positive blood culture from the peripheral vein with one of the following criteria, like catheter tip segment that match the organism's growth, at least threefold higher number of organism growth, and growth of catheter drone culture that is occurring at least 2 hours after the growth of the same organism in a peripheral blood drone culture. So all these definitions are part of a strategy that has been already described on how we can implement and reduce the rate of CLABSI. Part of this strategy is to use chlorhexidine-coated catheter. The use of antiseptic impregnated intravenous catheter has been studied since 1999. So, and there were big studies that mainly concluded that central venous catheter impregnated with a combination of chlorhexidine and silver sulfazidine were more effective in reducing CLABSI than in regular catheters. Further meta-analysis and studies comparing a conventional catheter with antiseptic impregnated intravenous catheter demonstrated that the positive cultures are more or less similar, but what is different is that the number of length of stay of the patient is less when these devices are used. And a recent Cochrane review showed that patients who receive non-impregnated catheters and impregnated catheters have lower, the patient with the impregnated catheter have lower incidence of birth-theme infection than those who didn't have impregnated catheters. So the benefit of this catheter in reducing the catheter coagulation varied according to the study setting, but there was always a benefit in those patients who had this catheter in the ICUs. So further studies have shown that the chlorhexidine and silver sulfazine coated catheter is more efficient when the patient has a catheter for a period longer than 48 hours. And this was a suggestion to consider this patient, especially for patients who are expecting a longer permanence in ICU. And in this case, the septic patient or even the COVID-SARS patient is a typical example of a patient who has a long staying in not only in the ICU, but even in the hospital. So there is a diabolic ICU triad, as I defined, that is a mixture of altered coagulability, that because the patient who is septic is both hyper and hypocoagulable. There is an altered immune status that is favoring the infection rate, and there is even an altered hemodynamic status that is reducing the flow. For this reason, we should have a catheter that can have a variable flow rates according to the need and the condition of the patient, and even the timing when the patient is requiring an exam. We should prevent the infection, and we should reduce as much as possible the size of the catheter in order to keep the catheter to vein ratio in a safety margin. So a recent study published by Dr. Timpson years ago was discussing on which site, and the site that was suggested for especially longer catheterization was considered the subclavian approach, even if this study was clearly biased by some factors like the lack of power injectability that in 2003 was not still so present. So more recently, the publication that we did with other colleagues together with the European Society of Anesthesiology focus on different approaches on especially when a patient should require a long catheterization, and both the axillary vein, the superficial femoral vein, and tunnel IGV have been considered for longer-term catheterization by using central venous catheter, both power injectable and non-power injectable. So our approach at Cleveland Clinic is quite simple. We are using for all our patients a power injectable chlorhexidine coated catheter. For peripheral VIS, we approach to have the catheter removed within 3 days. We have a maximum indwelling time for PICC lines of a maximum 2 months, and for the ICC, for the CICC, for maximum 21 days. If longer, the patient needs to switch to a PICC. The RIC catheters that usually are placed for a major trauma, for hepatobiliary surgery of massive hemorrhages, needs to be removed for prior to ICU discharge or post-operative day 3. These catheters are highly affected by the risk of thrombosis because usually are bigger catheters inserted in a peripheral AV. And the MAC usually is removed on post-op day 3, or if later, because the patient still require a PA measurement, you are considering day by day the requirement for the removal. We are removing all unnecessary catheters, and we do a daily infection control runs to check all the catheters. And it was quite significant, especially during the last period with the COVID, because we have a very, very low rate of CLABSI, despite we were quite busy in our ICUs. So to conclude, there are even some studies regarding the use of PICC, for example, in ICUs. PICC that usually were considered to be very high thrombotic, in the most recent studies have not shown a higher risk of thrombosis compared to other catheters. The only the study that is related to neurointensive care, where PICC were placed by neurointensivists, is showing a very, very low rate of complication. And even in this very high sensible scenario, there is a possibility that the patient will have a very, very low risk of infection and complication. The study that is showing again the low risk of complication comparing PICC to traditional CVC is showing that even in neurointensive care units, the rate of complication or even CLABSI is the same when both PICC and CVC are placed in neurocritical patients. Our data are showing that year by year, since we opened since 2016, are showing a very, very reduced number of CLABSI. And this is mainly a matter of teamwork in terms of catheter choice and even of care to the patient, and to target mainly to the zero complication, as have been presented already. So going back to the impossible Mr. Brown. Luckily, Mr. Brown had a volume resuscitation that corrected the emergency anemia. The respiratory failure was due to low oxygen delivery, and as soon as we recover with the transfusion, the oxygen delivery, the patient recovered. There was a close monitoring of the central line that was placed, and after 1 day, the PA catheter was removed. And in this case, we quickly moved Mr. Brown from the ICU, and we discharged the patient to the rehab. So, in summary, CLABSI prevention is based on bundles and teamwork. Without teamwork and bundles, so our goals are just a wish. Our patients, especially the ones in ICU, as I define, are very volatile. They can move from hyperdynamic to hypodynamic states, from hyperload to hypoload. And this is essential to understand even which kind of catheter we need, and we need even a volatile catheter. The catheter choice is fundamental in our patient journey. And never forget the patient. Never forget that Mr. Brown as a story, and we can help Mr. Brown to go out to the hospital and meet again his family. So these are my references, and I really thank you all for your participation, and for you, Anil, for your presentation. Thank you very much.
Thank you, Massimo. That was a fabulous talk. I think the concept of catheter to vein ratio is really one that's very important to get across to the audience today. And I think you've done that very well. So thank you very much for that. I just want to head to our last poll before we do the Q&A session. Okay, everyone. So this final poll is a little bit different to the others, but there's 4 statements there that I would like you to rate from the most important to the least important. So if you drag the statements up and down, you can move their relation on the page. So if we put what we think is the most important at the top and all the way down to the least important. So The statements are: it would be great if someone could help me reduce the risk of catheter-related infections in my department. It would be great if someone could help me reduce the recatheterization, spend linked with the wrong catheter selection, a time thing. It'd be great if someone could help me set up catheter selection guidelines depending on my patient's future needs. And it would be great if someone could help me simplify the procedure to place a CVC. So have a look at those, and please rank the statements from the ones that are most important and the least important at the bottom. So reducing the risk of catheter-related infections, someone who could help you reduce the recatheterization time because you've placed the wrong catheter in the first place. It would be great if someone could help you with catheter selection guidelines, which I think we'd all find very useful. And if someone could help me simplify the procedure to place a CVC. So please, everyone, have a vote, have a go at that. Again, please let the questions flow into the chat box so we can get to the expertise of our panel and ask them any questions that are on your mind and any questions that have come to mind during their 3 very, very, very good talks. So we're getting lots of votes in now. And I think that the focus has been varied over this webinar to do with infections, but also this concept of power injection for CT scanning, which is very important for lots of our ICU patients. So have a think about this ranking system that we've got in front of you, but also please think of any questions that you'd like us to ask the panel. We've got a few ones to go with, and we'll start off with those shortly. And I've got a couple actually, which I'd like to ask the panel about as well. So give you a couple more seconds just to vote, and you can see that it appears that catheter-related infections are the big worry for most people, and we'd like to see those being reduced. So that's fine. Okay, so we're going to head to the question and answer session now. I've got the panel all assembled on your screen for you there, and thanks very much for all the questions that have been submitted, and we'll try and get through as many as we can. I've got one that I wanted to kick off with, and I thought if I ask Antonio and Massimo to comment first, and then bring Mark in at the end just for his comment. And it was mainly around, obviously, COVID. We can't do a webinar without talking about COVID. But how has COVID impacted on the selection of lines that you've placed? Because we've had some anecdotal evidence that there's been an increase in line infections during COVID. I don't know if you've seen that yourselves. Antonio, would you like to take that first, or Massimo?
Oh yes, I'm not sure of the meaning of the question. You mean would you repeat it, please? Because there's a small issue I didn't understand.
Sorry, Antonio. So during the COVID patients, have you had any? Has that impacted on the type of line that you've been citing, central versus PIC versus peripheral versus anything else?
Both me and Massimo had faced a tremendous impact in vascular problems with COVID patients. So both me and Massimo contributed to a guideline that we published on the JVA. And what I can tell you is that first, bedside procedures are compulsory. We must not make patients go around the hospital. Second, while proning patients, we had to face different approaches to the central venous compartment. So we increased the femoral route, the superficial femoral route. And in my hospital, we had a huge increase in antiseptic coated catheters because especially in the intensive care units where COVID patients have overwhelmed our hospitals, because a common evolution of this disease is that in the first phase you have a respiratory failure due to the virus and to the ARDS. But after that, after 10-15 days of ICU stay, infection rates from any organ start to increase. And in our country, I have to say, in our hospital, and we try to spread this culture in the country, is that if a patient is bacteremic, so if he's got a bacterial sepsis, we must avoid that the new device we have implanted becomes a source of infection itself. That's the reason why we choose antiseptic coated catheters. And these patients are used to undergo contrast enhanced examinations despite the use of ultrasound. So we use antiseptic and power devices in these patients. We hope to have a huger amount of antiseptic and power PICC lines. We haven't got them available for all patients by now. Our hospital bought them only for a specific kind of patient, that is the hematological patients. So we cannot use them for all the patients we would like to.
Thank you, Antonio. Massimo, did you have any comments?
So to answer to your question, we had a different approach. So we didn't have this rise of CLABSI as could be expected. So the different approach that we had was that we were a little bit prepared to this pandemic when the wave hit the UAE. And so what we did was to have a specific and dedicated team that was only inserting lines. So our anesthesiologists mainly were running day and night together with the nurses, and they were placing day and night bedside lines or mid lines or even peripheral IVs if the patient was requiring a peripheral IV. So we follow mainly the protocol that we published with Antonio and even Mauro Pittiruti, and that was very, very helpful. So to answer your question, we didn't have this kind of problem. The advantage was that we use only chlorhexidine-coated catheters and power injectable. What we noticed was that we did less CT scans than before, because it was more difficult to manage the patient around the hospital. The patient were very critically unstable, and so most of the times it was very, very difficult to move the patient. So initially we planned to do like 3 CT scans for the lungs, and then we ended up to a kind of 1.2 in average CT scans of these patients. But the answer that I can give you is that if you have a dedicated team who can select the catheter and manage the catheter, you don't have any increase of the CLABSI.
Thank you very much. Mark, I'd just like to bring you in at this point. Did you see a rise in CLABSI during COVID?
Yes, I think a number of reports now increased catheter-related CLABSI relationship to COVID. Interestingly, both in COVID.
We're just having a slight problem with your sound. Could you just mute yourself and then mute yourself again? Just
sorry, I haven't done.
Okay, unmute yourself now. Just see whether we can.
Is that better?
Yeah, that's a bit better. Thank you.
I apologize for that. But we've seen increased CLABSI or CRBSI in both COVID. Both the COVID-positive and COVID-negative patients. It's already been related why that might be possible in COVID-positive patients.
Okay, Mark. Sorry, we had a bit of a sound problem there. I'm sorry about that. Okay, we'll just move to another question. So we've had a number of questions coming in. I just wanted to ask the panel about their views on multi-lumen catheters. There's CVC lines which have 4 lumens, 5 lumens, even more sometimes. Do these cause problems? How do you manage patients that need more lumens? Massimo, would you be able to?
So the multi-lumens catheter is a never-ending program. So we start with the 5 lumens, and then after sometimes 3-5 days, we end up with 3 lumens. The 2 lumens are in excess. So again, standardization is the key. So we decided in our hospital, or even in our enterprise, not to move more than to the 3 lumen catheters with, again, power injectability and chlorhexidine coating. So this is the reason that in case we need further accesses, we place the second one. And when we don't need it, we take it out. So the reason of the multi-lumen is that once the lumen is inside the patient, we cannot take it out. Very simple. And the standardization is the key again. Everyone inside my institution has decided we have to use the same kind of catheter for everyone.
That's great. And I'll just move on to another question. Antonio, I don't know if you can take this one. So are subclavian vein catheterizations associated with lower infection rates and thrombosis when compared to internal jugular or femoral lines?
This is quite an old issue, and we have solved it stressing the fact that controlling CRBSI is a multi-tool issue. That means, yes, we noticed, and the literature noticed, that a subclavian exit site, not a subclavian entrance. I mean exit site. The exit site is the key in this situation. Is less prone to infection because of standard colonization of the skin, as Rupp can teach to us. But this is not the only issue that controls infection rates. And I have to tell you, within the hospital, the most frequent reason for infection is the endoluminal route. That means that the operators must be really stressed not to access the line without antiseptic precautions.
Thank you. Okay, so the final question we'll take is just what was I going to say? This one is, so what's the best line to use for the patients in your ICU? Which is your favorite line?
Who should answer?
Massimo first, then Antonio, and then Mark, you can have an opinion as well. We are shifting quickly to PICC lines. So, and I tell you why, because mainly we are shifting to have our nurses placing PICC lines on the bedside. So whenever it's easier for the patient to get the line, and if we need this kind of line, we prefer to place a line that can stay for longer, and especially when the patient has been discharged from the ICU to the ACU, to the acute care unit.
Well,
Antonio?
I'm not an intensive care, and I'm not an intensivist, I'm a surgeon, but we have critical care patients in our ward. And I will tell you that I haven't got a single answer. We have an algorithm. And what I can tell you is that we use only power injectable devices. And we have large indications for antiseptic coated devices, as I showed you in our paper. And as concerns the approach, it depends on the algorithm. That means if we have heavily colonized patients in the region of the mouth, or with tracheostomy or something like this, we try to stay away from here and then have PICC lines if veins in the deep arm are available. That means are large enough. And that's just to summarize our approach. The key point, as Massimo Lamperti says, is standardization, is the algorithm.
Okay, Antonio, thank you. Mark, I'm afraid I think we still got some trouble with your microphone. So, and the time actually for the webinar is up. So again, I'd just like to really thank all three of our speakers, Massimo, Antonio, and Mark. Thank you so much for very informative talks. And I'm going to hand back to Maria from Teleflex.
Before closing, I would like to remind that you are still on time to ask to get in touch with our team by clicking the button here on the page. If we haven't answered your questions, as you have submitted with an email address, we will respond to you privately. I would like to inform you that this event will be available on this webpage for the next 6 months for those who have missed it. You will receive soon a satisfaction questionnaire. We would like to receive your feedback to help us to improve for next events. We hope you enjoyed this event, and thank you so much to Professor Ormis, Dr. Rupp, Dr. Greca, and Dr. Lamperti to share your expertise and your valuable know-how. We wish you all to enjoy the rest of the day, wherever you live, and thank you so much.